Hello and good afternoon, everyone. We are very excited to share this presentation. I am very honored. My name is Dawn Wyatt. I'm very honored to introduce our presenters and experts from UW Medicine, Dr. Susan Reed and Dr. Linda Mihalov, who will be giving a presentation on perimenopause and beyond. This is a series brought to you by UW Medicine and our publication, Right as Rain. I'm going to give this I'm actually going to jump in because we were a few minutes late starting our program. We have a lot of participants today, which is just such a treat that so many of you are interested in this conversation. But before we start, just a few housekeeping rules. This will be, our experts will be going through information and presentation. And if you have questions, you can submit those through the Q&A function at the bottom of your screen. We'll be reviewing those questions. And at the end of the presentation, we will be having live Q&A at the end of today's meeting. So without further ado, I'm going to hand this off to Dr. Susan Reed. And I hope everyone enjoys today's program. Thank you.
So thank you for joining us. Dr. Mihalov is going to run the slides. So next slide, please, Linda. These are my disclosures. Dr. Mihalov did not have any disclosures, and we're just going to hold there for a second. By way of background, I am Vice Chair for Research and OBGYN professor, and Dr. Mihalov is a clinical professor. I am President-elect for the North American Menopause Society, and Dr. Mihalov has spoken broadly on topics for menopause. Next slide, please. Next. Yep, just keep them flying, Linda. So these are the objectives for today. We're going to briefly discuss what is menopause, what is the transition, and what is perimenopause. What are the differences there? I'm going to talk about the symptoms and the physiology behind what women are feeling. Talk about healthy lifestyle, preventative health, and then finally therapies. Next slide. So menopause is the final menstrual period, that final date. And we use that term more broadly often, but it really is a single day in time. 95% of women undergo that final menstrual period between the ages of 45 and 55. And the average age in the US is between 51 and 52 for Caucasian women. The important sign that menopause may occur for you in the next 1 to 2 years is when you have a gap of at least 60 days with no bleeding whatsoever when you've been having fairly regular periods. Next slide. The transition is a period of persistent irregular bleeding, symptoms such as hot flashes, poor sleep, and mood, prior to the final menstrual period. So it ends with the final menstrual period, whereas the perimenopause extends to 1 year following the final menstrual period. Premature ovarian insufficiency, used to be called premature menopause, occurs when the final period happens before the age of 40. Next slide. So I'm going to do a pop quiz here, and Linda gave the answer, so we're going to jump right in here for those of you that were listening. The age that you would anticipate the most bothersome symptoms are ages 50 to 54, but the duration of symptoms that are bothersome on the whole are 7.5 years. Next slide. Next. And this slide next. This shows the bell-shaped curve of symptoms with the late transition there to the middle left, the early postmenopause to the middle right, and the final menstrual period is right there with the dark arrow, and you'll see sleep problems and hot flashes peaking around that final menstrual period. Next, please. So another quiz, what are the most common symptoms that occur around the time of menopause? We all classically think about hot flashes and night sweats, but here is menstrual irregularity. Everybody gets it, and you might come into our emergency room with hemorrhaging or flooding because of tough bleeding problems. You may even feel anemia. Next, please. So here this gives you an idea of the proportion of women complaining of symptoms, and as we said, 90% have menstrual irregularity. We see hot flashes and night sweats in around 80% of women, poor sleep, mood changes, depression, clustering right around 40 to 60% there. But things that we don't talk about as much are changes in cognition, such as ability to concentrate, word finding, and then musculoskeletal problems we talk about very rarely, and diminished libido, very common, but not so talked about. The irregular bleeding starts to occur in the early 40s, such that we see shorter periods, less than 28 days, and then in the later 40s, you start to space out your periods, and that's the norm. Why do we see heavy bleeding in the late 40s? Because you stop making eggs, and when you stop making eggs, you no longer make the hormone progesterone. Estrogen dominating results in heavier, thicker lining of the uterus, flooding, sometimes hemorrhage, and even transfusions. We treat this with progesterone, and Dr. Mahaloff is going to tell you more about that. Hot flashes are a sensation of warmth or skin irritation, perspiration. They tend to start more in your trunk. You feel like your head's going to kind of pop off with heat. They last for seconds to minutes. You can have heart palpitations, a sense of a heart palpitation. I think there was a question about, I feel this heavy heart thing happening, and these are real. A sense of anxiety, formications are feeling like you have kind of ants under your skin. They commonly start before menopause, not always, but most commonly. And they happen because you have dilation of the vessels and then perspiration to dissipate heat. Men can get hot flashes when we give them hormones to treat prostate cancer. And these symptoms are controlled by an area in the brain called the Candy neuron complex. And so this is new, exciting information that tells us why we have hot flashes. Next, please. Some predictors, and so Linda, run the pointer there on the shorter predictors of hot flash duration. So shorter durations over on that left-hand side. If you have your first symptoms around the time of your final menstrual period, then it's going to be shorter. Asian women, Japanese, Chinese, shorter periods of hot flash durations, non-Hispanic women, women with a higher education, never feeling stressed. So that's none of us probably on this Zoom webinar. And so that's not going to be helpful. And no depression, no anxiety with COVID. I think that would also be pretty hard right now. What we see for longer duration of hot flashes is when you really start to have your symptoms in your early 40s. You may be having a long perimenopause or transition. If you're African American, we know there's a longer duration of hot flashes there. Hispanic ethnicity, and then with less than college education. If you feel stressed, have depression or anxiety, then you're going to have a longer duration of hot flashes. Other factors contributing, certainly financial strains, and I would put that under stress. Single folks, smokers, poor social support, and those with a body mass index of greater than 30. Next. So sleep. It can be pretty rough, and these are a lot of the folks I see in my office. Dr. Mahaloff could weigh in there, but people can manage their hot flashes for quite a while, but when you're not sleeping, you're not functioning. What we know about this, we used to think it was directly related to the hot flashes, and indeed those that have more hot flashes have worse sleep, but they're not directly linked. So it's not necessarily, women will say they first wake up and then they might have the hot flash later. It's not the hot flash that makes you wake up per se. Next, please. So what is it about the musculoskeletal changes? Well, your joints, your muscles, and your bones are just chocked full of estrogen receptors. And so your musculoskeletal system is responding to estrogen. Aches and pains are much more common. Frozen shoulder diagnoses are higher during this period of time. We see decreased bone density and osteoporosis with fractures starting to begin. The muscle mass and strength is dependent on testosterone. So Dr. Mahal, circle over the testosterone diagram there. So see what's happening there, nice and high in our 20s, but then it's a downward slope. And we often think of testosterone and libido, and indeed that is linked, but you don't see things just falling off a cliff at 50. So that doesn't explain the libido. But what we do see is fatigue, weakness, decreased muscle mass really becomes problematic. Next slide, please. So what about mood? And what about that sense of sort of spaciness? I can't concentrate. It is real. Let's talk about mood first. So those with a history of postpartum depression, major depressive disorder, or premenstrual dysphoric disorder, or PMS, that's really severe, are more apt to have depressive symptoms at the menopause transition, and it's usually the late menopause transition. These almost always improve when you get on through to the other side. Studies have shown diminished ability to concentrate, verbal memory, and diminished processing speed. And libido and sexual function also decrease in the transition. It's hard to tease that one apart. Often we talked about the lower testosterone, but if you're sweating in your sheets like crazy, you're not able to sleep very well, you tend to not have a high sex drive. Next, please. So I just want to briefly mention, so what about the post-menopause? What do we see? Well, there's my hand on the right-hand side, unfortunately, because I am going to be 70 soon, and that is what we really start to see happening to our skin, versus that hand on the left side might still be the perimenopause, perhaps. But I want you all to focus on that little arrow there, pain with sex. So post-menopause, we see some of that starting in the perimenopause that we're talking about today, but much more common in the post-menopause. And why is this happening? Our skin changes dramatically. The collagen cross-links are supported by estrogen, and they actually break somewhat, and your skin changes are dramatic. Next, please. These are the genitourinary symptoms that start in the perimenopause, painful intercourse, but these only magnify through time. There's dryness of the vagina and the genitals, the outer genitals. The skin becomes friable. The urethra or the bladder opening can be inflamed with some painful urination, urinary frequency, and recurrent urinary tract infections become more common. Next, please. So in summary, and I'm going to pass the baton here to Dr. Mahaloff, but I just want to say every system, every tissue can be affected by your reproductive hormones. That hormonal changes of menopause interact with normal aging changes. So this gets a little bit tricky. We're all aging all the time. How much of this is aging versus related to hormones? And that intersection is a challenging area of research. We don't replace hormones anymore. So Dr. Mahaloff is going to tell you about the estrogen and progesterone treatments that are possible, but those doses are far below anything your body is producing when you are in a reproductive stage of your life. And in fact, far lower than any of the hormones that are replaced with, for instance, the combined oral contraceptive pill. This is a dynamic period in your life. It's not fixed, not a single point in time. So you're kind of on a, I don't know, a treadmill, if you will. And some people feel like they're on the mouse wheel, just trying to get off of it. Remember that the greatest changes occur the 2 years before and the 2 years after your final menstrual period. And you do get on through it to a new place that once you kind of adjust to these new changes, life continues to be great. So Dr. Mahaloff, take it from there.
Thank you, Susan. So what can we do to get ready for menopause? The first thing is the easiest, of course, maintain a healthy weight. I say that with a wink because that's not so easy necessarily. My quick tip for that is avoid sugar. Exercise is important, weight-bearing exercise, especially because bone mass bone loss increases after menopause, so we want to keep our bones as strong as possible going into it. To reduce risk of cancer and heart disease, of course, avoid smoking, limit alcohol to less than 1 drink a day, less than or equal to 1 drink a day, and use your sunscreen. It's important to make sure you're getting enough calcium and vitamin D. And if you don't get it in your diet, which is the primary choice, at least 1,200 milligrams a day of calcium and 800 international units of vitamin D, then you may need a supplement. And a plug for visiting your gynecologic care provider every year. Even if you've been told you don't need a pap smear any longer, it's good to check in. So the most important thing you can do to improve your health and decrease early death is exercise and maintain a normal body weight. So let's go through some cases. Donna's 49 years old. She's having irregular heavy periods, sometimes 8 weeks apart, sometimes only 3 weeks. She's having a lot of breast symptoms and more PMS. She goes to the doctor, her pelvic ultrasound is normal, the uterus is fine, she has a normal thyroid function, but she's anemic. What can she do about this? So when we're talking about treating heavy menstrual bleeding or abnormal menstrual bleeding, first we have to decide whether contraception is necessary, because that can make a difference in what we choose. Because as Dr. Reed told you, progesterone is missing or is not as robust in this time frame, we add back progesterone to the hormonal mix. And that can be done with progesterone medications that you can take either in cycles to mimic your natural cycles, or you can take them continuously, which would basically eliminate the periods. Eliminating the periods can often also happen with use of a progesterone releasing IUD. The most common one is Mirena. Most people who use that stop bleeding completely. And that can also be handy as we move into menopause, because if you need estrogen therapy later on in menopause, the progesterone in the IUD can serve as the progesterone component, and we'll come back to that. Oral contraceptives or birth control pills can be very effective for treating the symptoms that come along with the perimenopause. So birth control pills are not just for college students any longer. They can restore regular periods, reduce the pain with menstrual periods, reduce the amount of bleeding, can also suppress those hot flashes and night sweats, help to maintain bone density, and can improve acne and PMS symptoms. And some birth control pills are specifically FDA approved for that indication to help with PMS. So case number 2, Taisha is 51 and she hasn't had a period for over 2 years, and she thought she was skating through the menopause, didn't have hot flashes or night sweats, but now she's noticing that her vagina is getting dry and sex is painful. She's not really interested in having sex anymore, and she wonders what's wrong with her. Is this just aging and just what she has to put up with? So what can we do for this problem? So just to remind you, the World Health Organization put out this graphic for Valentine's Day this year, this making sure that we all know that we're entitled to have comfortable, painless, satisfying sex lives, regardless of age. So this can be a big problem because a lot of women don't talk about it. At least half of postmenopausal women have this problem of pain with sex or dry vagina, but only a small percentage are treated. And that's unfortunate because when sex is good, it adds some to the value of the relationship, but when it's bad, it really can diminish it by quite a bit. And this is especially problematic for this 3.8 million survivors of breast cancer in our country, who are usually told that they can't take hormone therapy. And a lot of those are quite young women. So this is an important thing to pay attention to. And many people are unaware that this problem can continue and get worse over time. So even once you've gotten past the worst of the menopause. So our first line of management for vaginal dryness and discomfort is the use of lubricants with sexual activity, as well as using a moisturizer. And a moisturizer is something that you would use on a regular basis, not just when you're having sex. I put coconut oil on here because that's a very easily available product and it's not very expensive. It comes as a solid, you liquefy it between your fingers, and then you can just apply it to around the vaginal opening inside the vagina. And that's a good way to moisturize your vagina in the same way you would moisturize your skin. Lubricants are things that you would use with sexual activity, and they come in water-based and silicone-based forms. The silicone ones tend to be more slippery and last longer than the water-based. This is just a list of some of the most common ones. The ones that are I usually recommend over the years have been the Pure products and Uberlube, which you usually need to order online. The other ones like KY Jelly and Astroglide you can frequently get in the drugstore. The moisturizers include products that are similar to the coconut oil, and several of these contain hyaluronic acid, which you might have heard about because now it's popular in facial moisturizers as well. So good for the vagina also. And if those products are not sufficient, then we have vaginal estrogen, which has been around since 1946. So it's been very used for many years, very well tested, and is now available in several different formulations. We have vaginal tablets that you put in the vagina twice a week. We have a vaginal ring that you put in once every 3 months and leave there. We have estrogen cream that can be applied around the opening or inside the vagina. And we have inserts that you put in. And some people need more than one of these products. And some people who take hormone therapy in the body, systemic hormone therapy like pills or patches, will still need some vaginal estrogen. Cost can be an issue. Unfortunately, the insurance companies do not necessarily cover all the full range of products, which they should, but they don't necessarily. So sometimes that's an issue. One of the things I would like you to know about vaginal estrogen is it really has the power to restore an older vagina into a younger vagina. So I have seen women whose vaginas have looked very much affected by the low estrogen, and they have been restored back to their youthful state with vaginal estrogen. The two important things that estrogen does for the vagina are contribute to moisture and lubrication, but also estrogen helps the vagina to be able to stretch. When there's not enough estrogen around, the vagina is like a tube, a solid tube that doesn't have much give to it. So the vaginal estrogen adds to that flexibility. This is just to let you know what these products look like. The ring that you put in and leave in for 3 months, these inserts that you insert yourself with your finger, and the vaginal tablets come with an applicator that you then throw away. There's another product which is a derivative of testosterone and androgen called Intrarosa that is also a vaginal insert that works in much the same way as the estrogen. It's a little bit less convenient because it's used every day. It's important to know that these products are not associated with an increased risk of breast or uterine cancer, cardiovascular disease, or stroke. So they're considered safe for most women who have a history of breast cancer, although women with this history should always check with their doctors first. It isn't necessary to use progesterone along with them. But be aware that the FDA requires the manufacturers to put the same labeling and warnings on these vaginal products as they do on the products that you would swallow or put on your skin. And that means it's a little bit scary when you read those instructions, when you read those warnings, which really scientifically do not apply to these vaginal products, but that's where we are right now with the FDA. What about applying energy to the vagina? You might have heard of people who've gotten their vaginas lasered or treated with radio frequency energy. And there are many people who are looking for a non-hormonal treatment, although what I've mentioned is that vaginal estrogen is quite safe for the majority of people. The FDA has warned us against the use of these devices to perform vaginal rejuvenation. And you should know that the FDA clears these devices because they've been approved for use elsewhere in the body, like laser resurfacing on the skin, but they aren't really approved for this particular use. And the FDA encourages more research, really comparing these devices against other treatments before they're widely accepted. And the North American Menopause Society, which Dr. Reed mentioned and which you'll hear us referring to, is really a good source for guidance for us. And they recommend that we really should have more research before we widely recommend this to know whether it's safe and effective. So case number 3, Robin has only had one period in the last year. She's having worsening hot flashes and night sweats. They're interfering with her sleep and interfering with her work. She tried increasing her soy intake. She's taken black Cohosh, which worked for her friend, and she tried some over-the-counter progesterone cream. Are there any other options? So looking at the data about black Cohosh, this is a beautiful study done several years ago by Dr. Reed, where they compared placebo. This was the baseline hot flashes, so a large number of these women had hot flashes at the beginning of the trial, and they were randomized to receive either black Cohosh, a multi-botanical that had multiple different herbal products in it, a multiple that also had soy in it, and placebo, or estrogen and progesterone. And you can see here that all of the groups of women over time had some improvement in their hot flashes, but none of these non-hormonal groups had significant improvement. This is the estrogen group. So down to, a very small percentage of hot flashes. So we know that estrogen really works the best. If we're not interested in estrogen or can't use it for one reason or another, there are some other non-hormonal options. The medications that have been used for psychiatric purposes in the past have actually some good evidence for benefit when treating hot flashes and night sweats. Gabapentin is a medication that was originally a seizure medication, anti-seizure medication, and it can be helpful with promoting sleep as well as reducing hot flashes and night sweats. These other are various different antidepressants, some of which are specifically indicated for this purpose for menopausal symptoms. And these can be useful for people who have a tendency to have problems with mood and with either depression or anxiety around menopause, and are certainly worth a try. The reduction in symptoms, the benefit is not as great as would happen with estrogen. So if our patient decides that she wants to go on hormone therapy, then what are the things that she should consider? So estrogen, as I said, is the most effective treatment. It also improves mood and depression, sexual function, the health of the vagina and the bladder, reduces bone loss and fractures, reduces coronary heart disease when it's started early or within 10 years of the menopause onset, reduces new onset of diabetes, and is considered safe for most people if started within the first 10 years after menopause. The risks are that estrogen by itself can cause cancer of the uterus or precancerous conditions. So it must be used with an adequate dose of progesterone and an adequate duration. And the blood clot risk and stroke risk appear to be reduced when using lower dosages and the transdermal or skin patch version as opposed to pills. And in women who only need estrogen, who don't have a uterus, that's associated with a lower risk. And that's also a lower risk of breast cancer. Breast cancer risk is higher in those taking estrogen and progesterone together, and it may depend on the dose, the duration, the type of hormone. So breast cancer was brought really to the forefront by the Women's Health Initiative, which was published 20 years ago. And in this study, where women who did not have symptoms of menopause were given estrogen and progesterone, there was an increased risk of breast cancer after 3 to 5 years in the people who took the combination, but no increased risk of breast cancer in women who'd had a hysterectomy, who only needed the estrogen. And the hormone therapy does not appear to alter the risk for breast cancer in those with a family history, which is reassuring. And the most commonly used current regimens are quite different than what was used in this original study. So estrogen luckily is an easy molecule. It's an easy drug to get into the body. We can swallow it in pills, we can put it in the vagina, we can put it on the skin in the form of a patch, a gel, a lotion, or a spray. It is available in many different dosages, which allows your doctor to titrate or to decide what is the right dose for you. Most of the available options are estradiol, which is the same, exactly the same as our body's primary estrogen, the one that we have all the receptors for. And there are combination products that have both estrogen and progesterone in the same either pill or patch. Progesterone is a little bit more difficult molecule to get into the body, which is why it's important how it's delivered. There is a natural progesterone form that we commonly use, which happens to be suspended in peanut oil in the capsules. Norethindrone is another common form of progesterone that's in many birth control pills. Progesterone creams that you can buy over the counter don't really count as progesterone, and so they are not reliable for this purpose of opposing the estrogen in the hormone therapy. And progesterone, depending on the regimen, can be given every day or at intervals, and both have been shown to protect the uterus, which is really the only reason that the progesterone is in there. All the benefit, pretty much all of the benefit, comes from the estrogen, but the progesterone has to be there if there's a uterus to protect it. What is an increasing frequency of use now is the progesterone IUD, which delivers the progesterone into the uterine lining, which is really the only place where we need it. That's considered an off-label use, but that is commonly used. So we have concerns about compounded or so-called bioidentical hormone therapy. It has not been shown to be more effective or safer than pharmaceutically produced products. It's not regulated or monitored in the same way. The labeling does not outline the risk very thoroughly. And there's also no evidence to support testing the saliva to monitor estrogen levels. We're not trying, when we treat with hormones, we're not trying to achieve a certain dosage. We're trying to relieve symptoms. So we want to use the lowest dose that works for symptom relief. And so generally the compounded therapy is not recommended because we have so many standard forms available that are essentially bioidentical. So what is the most effective therapy for hot flashes? We've talked about these options, and really estrogen and progesterone is the most effective in terms of most likely to resolve symptoms. So in summary, it's really impossible to predict what a particular person's menopausal experience will be like. It's good to go into it as healthy as possible and take good care of yourself in general. There are multiple options available for management, both hormonal and non-hormonal. So that is the really reassuring message we want to give you. The treatment should always be individualized to each person's needs. So it's not necessary for every woman to take, something standard. It's all individualized. The menopausal hormone therapy is safe and effective for many when it started before age 60 or within 10 years of menopause. And I should also say that the vaginal estrogen therapy is extremely safe, and the vast majority of women are good candidates for using vaginal estrogen. How long should you use it? There's no reason to stop at any particular time when we're talking about the vaginal estrogen. That is really beneficial for the long term. So these are our references. The North American Menopause Society, which we've talked about several times, is an excellent resource for the public as well as for clinicians. The Women's Health Initiative, which we talked about the study briefly, you can look in more detail about that. MS Flash is a consumer resource for you, and the study of women's health across the nation was based here in Seattle and also gives you more information. And we've included our email addresses. Actually, this is erroneous. My email is ls as in Sam m25@uw.edu. And I'm going to turn it over to Heather for questions.
Hi, everyone. I'm Heather Van Dusen. I'm the Director of Content at UW Medicine. I'm also the editor of Right is Rain, the publication that is sponsoring this today. So we have so many wonderful questions. I'm hoping to get through many of them, but if we don't, I'm so sorry if we don't get to your question, but we're going to try. The first one I'm going to ask is really sort of subjective. Why aren't we talking about perimenopause more in society? Why don't we see it in the media? Why is it sort of this quiet topic? Do you have any opinions on that?
Go ahead, Susan, do you want to
Sure.
handle that one?
So I think we all recognize that menopause, and we've thought about that as a time that's midlife in the 50s, but indeed, as we've talked about today, it does start in the 40s, and these symptoms that are harbingers of what will come were not well recognized by the scientific community, I think, until more recently. And it was downplayed by your providers that menopause was not talked about at all. So I think that's contributing. I think we see in the media more about the flashy things happening in medicine, and we just aren't bringing out these important issues about women's health.
And I think, unfortunately, a lot of things having to do with older women are just not talked about as much. It's just not as glamorous. And that's really unfortunate because our population, the population is aging, and we are not willing to sit by and not do anything about it to enhance our lives. We want to be able to do what we can to live active, healthy lives. And there are many more options now than there were 30 years ago. So there's a lot more to talk about.
Great, thank you. We received a lot of questions about IUDs and their impact on perimenopause and menopause. And the first one is, if you're using an IUD, a hormonal IUD, or continuous birth control pills, how do you know? How do you know if you're in perimenopause or getting to that stage? And then when should you stop using an IUD?
I'm going to jump in on that one. So IUDs are a great way to manage really heavy periods in the late 40s. So that's common. And as you know, you may have light and scant periods or no periods at all. This is the one time that I test hormone levels, reproductive. So FSH and estradiol. I'll check hormones to see if women are becoming close to the final menstrual period. I usually don't in people having classic symptoms of menopause. Their periods are spacing out. There's no reason to check the reproductive hormones. So this is when you might get hormone levels checked. I don't encourage my patients to use regular dose birth control pills in the late 40s because of risk side effect profile with leg clots and strokes even. So you want to move to a lower dose combination pill, or switch to something like the IUD and perhaps use a much lower dose estrogen at this point in your late 40s.
Thank you. That's very helpful. Just a housekeeping reminder, if you could put your questions in the Q&A rather in the chat, I'll see them in the Q&A. I can see some that are coming through the chat. So just a reminder there. Another question that came through is, can women experience shortness of breath during the transition to menopause? Is that a common symptom?
I would say no about shortness of breath in general. You know, the palpitations, the heart pounding symptoms can be a symptom of menopause, but shortness of breath, I would get that checked out.
Agree. And sometimes when you feel short of breath, it actually is a heart palpitation.
Mhm. Mhm.
Okay, the next question is about flooding. So what is flooding? And my understanding is that's really, really bad periods. And is there a way to alleviate that maybe without hormones? Or are there any helpful hints to deal with that?
There's only one medication now called tranexamic acid that we use for really heavy periods, and it actually works on the clotting system. But the bottom line here is progesterone is so important. And I have some patients, and it looked like I saw in the chat, people don't tolerate synthetic progesterones. The lowest dose progesterone you're going to get is from the IUD. So something like a Skyla or Kylena have lower doses of progesterone. These are smaller IUDs. And then micronized progesterone that Dr. Mahaloff spoke about is the natural progesterone. And so it doesn't, it's the wimpiest progesterone we've got. It is not as strong as these others. So sometimes it's not enough to control flooding.
Right.
What do you do, Dr.
The
Mahaloff?
dose, the dose of micronized progesterone that it takes to control heavy bleeding is often so high that it makes people
Sleepy.
drowsy and sleepy.
So I tend to use like a 300 milligram, and that's pretty,
Yeah.
it'll hit you hard. It's
Yeah.
good to take at night if you're not sleeping well, but
Yeah, but there are multiple options for that, for managing that. And it's important to get that checked out, to not assume it's because of menopause, because it could be because of something wrong with the uterus. So there are multiple different things that can cause that problem. So
I'm just going to jump in specifically a precancer or cancer. So I saw someone in the chat had a 2-week-long period. That's not normal. That is not normal. So please see your provider.
Okay, we're going to continue on some symptom questions. So the next one is about night sweats and what to do about that. Are there any helpful hints?
There's a device you can put under your sheets that's a fan that you can get from Amazon that'll help cool you when you're, but the bottom line is hormones help the best. Dr. Mahaloff?
yes, I would agree. I mean, certainly dressing in layers, you know, there are, you know, nightwear that it's specifically intended to be cooling and that sort of thing. But if you're really bothered and it's really interfering with things, then looking into hormone therapy is beneficial. How long should you take hormones? I don't know if anybody asked that question. Usually we think of planning to take it for about a year once you get started on it. But there's no age limit. There's no duration at which we say you must stop at X age or you must stop after X number of years. It's an annual review. We go through every year. What are the benefits you're getting from this? What are the potential risks? And you know whether or not this is appropriate for you to continue.
So I ask my patients every year before they come in to see me to stop their hormones for 1 to 2 weeks and see how they feel. And if they feel miserable, they restart. But if they feel kind of okay, then we talk about decreasing doses.
We also received a lot of questions about mental health, the emotional up and downs that come with perimenopause and menopause. And how long does that last? And is it something that is that the new normal?
So that's been well studied. The late transition is most common that you're going to have these symptoms. First of all, if they are serious symptoms, do not ignore them. Don't chalk them up to just menopause, and hormones will not always fix these. So you should see your provider. Know that it's a normal physiologic process, that the brain is changing such that you're susceptible to mood changes.
And many of the treatments that we've talked about can reduce those symptoms and can really even out. Sometimes it's just a matter of time getting through the worst of the ups and downs. But you know, if you need it, there definitely are treatments available.
Okay, thank you. My next symptom question is about hair loss. Is there anything that can be done about that?
Well, this is a tough one. I'm going to jump in. So anytime you have reproductive hormone changes, you're going to have hair loss. So if you've been pregnant, you lose your hair around the time of pregnancy. Sometimes you get better hair, so it'll go up and down. When you have reproductive hormone changes, you're going to have hair loss. And with aging, we all have hair loss. We have lower testosterone with hair loss there as well. Linda, what do you recommend for treatments?
Well, the first thing is to check and make sure your iron levels are normal, because women who don't realize they're losing as much blood with their periods can get iron deficient, and that can certainly contribute to hair loss. Thyroid dysfunction is a very common cause of hair loss. So those are two things that are quite common in midlife. And so that's worth getting checked out with your provider. I don't have a supplement recommendation that I know of as being scientifically validated for this. And I have had patients who've said that their hair is different when they take estrogen, and that estrogen is beneficial for that. So probably has to do somehow with that same collagen thing we were talking about.
Yeah, I think it strengthens the hair follicles. Yeah.
Okay, another big topic of interest is brain fog. What is it, and how do we know it's related to perimenopause or menopause, or is it something more serious?
That's a great question. There are differences if you go in for testing for this. So this can be sorted out by testing for providers that are well-versed in dementia, changes for dementia, versus those changes that we see at menopause. They're real. So if we study them and you look at the changes through time, certainly menopause transition, these are real changes that we see as we study people longitudinally.
Right. So it's definitely real. Doesn't mean it's necessarily easy to treat. But I think that some of it also has to do with, we have a lot on our plates. And a lot of women in their 40s are dealing with aging parents as well as children going to college or younger children. And, there's jobs, it's a busy life. So I think it's a matter of, looking at priorities and making sure that you're taking care of yourself, which you're all doing by coming to this webinar today. So I think that's a good start at prioritizing your own needs so that you can take care of everybody else.
Thank you so much. There's a lot of questions about hormone therapy. One being, how early can you start it?
Anytime.
And in fact, an important thing to know is that women who go through menopause early, as Dr. Reed described, premature ovarian insufficiency, those are women who really deserve to have estrogen. We are meant to have estrogen until we're around 50. So if you've gone through menopause at 35, either naturally or because of surgery, your body deserves to have estrogen.
Not only deserve, studies show that you have increased risk for fractures, cardiovascular disease, and dementia if you do not get estrogen when you have an early menopause. So please take it. It's more than deserve.
Exactly. Well, that's what I mean by deserving it.
Okay.
In order to be healthy.
Yeah.
I think you answered my next question. Are there any risks to not using hormone therapy?
Well, there's
early menopause. Yeah, early menopause for sure.
Yeah. And the Women's Health Initiative study that we talked about earlier was designed in order to test this hypothesis. Could we take healthy people and make them even healthier by giving them all estrogen? Because that was a thought back in the in the 80s and 90s, was that estrogen was good for all of us. And it turned out from that study, well, maybe not so much. But it's not necessarily something that we should be giving every single person. But there are, I wouldn't say risks, there are consequences if you don't take estrogen. So For instance, there is no amount of exercise you can do with any amount of calcium that you can take that can be as good for your bones as estrogen would be. Now, you may decide in the grand, weighing the benefits and risks that estrogen is not for you, but that is one of the potential consequences. So the decision about that might have to do with what is your risk for osteoporosis? How likely are you to get it? Have other women in your family had hip fractures or gotten all hunched over from osteoporosis in their back? So this is what I mean when I say we have to individualize treatment, because for the risk benefit ratio is different from one woman to the next.
Thank you for that. There are also a lot of questions about weight gain and belly fat, and can hormone therapy help with that, or is that just a diet and exercise thing?
So good. We as a scientist, so Ms. Flash, I am a principal investigator for that research group, and the SWAN investigators have looked at this really carefully. What we see is a 1 to 2 pound lower weight in women who take estrogen. And if you think about it, 1 to 2 pounds here and there, it may not be, you really shouldn't take estrogen just to have a lower weight. It will provide you with a little more muscle mass. So we see a little better muscle strength and a little bit less weight around the tummy. But really, it's exactly what Dr. Mahaloff said. Exercise and calorie control is what, unfortunately, and a lot of this is age driven and has nothing to do with your hormones.
And the other thing about that is that it is reassuring to know that, many people are afraid of taking hormones for fear that they will gain weight. And there's no evidence from the research that hormone therapy increases weight.
It's kind of the reverse of the birth control pill. We say 1 to 2 pound weight gain. And at this point in your life, it's a 1 to 2 pound weight loss.
Right. And the doses, again, of menopausal hormone therapy are much, much less, a quarter or less of the dose of hormones in birth control pills.
Okay. Going back to birth control, how do you know when it's time to switch from, your typical birth control to hormone therapy?
So after the age of 50, the chance of carrying a pregnancy to term is less than 1% if you're not using birth control pills. So you sort of anchor on that. So at 50, I tend to start looking at the consequences, how someone might feel about becoming pregnant, and then gauge it on that.
Well, I usually try to have people stop birth control pills somewhere between 50 and 55. By 55, definitely, we're off. But and some people who are committed to continuing on hormone therapy can seamlessly transition from birth control pills to a hormone therapy product, and other people are just interested in going off and seeing what happens. But if you're using, it makes a difference if you're using either an IUD or birth control pills for birth control, as opposed to for treating the symptoms like we've talked about.
I'm more of a hard liner. There's a pill that's called loloestrin that it has half the dose of the other pill. So I'll get them onto that. But the other thing that we can recognize is the formulations of some of the postmenopausal hormone therapies have the same dose as the birth control pill for progesterone. It's the progesterone that provides the contraceptive. So it's an off-label use of a product that's safer for you when you get into your 50s.
Right.
Thank you. Is there any correlation between when you start your period and when you start perimenopause, menopause?
The way I've looked at the numbers, people who start periods earlier tend to go later, and people who start their first period later tend to go through menopause earlier, which is not necessarily what you want to hear.
Right.
I'd like to think if I started when I was 10, then I'm going to stop earlier, but not necessarily. But those are sort of population numbers. That's hard to bring it down to the individual level.
Interesting. Thank you. Let's see. So one question I want to ask is, what is the current training in medical school? What are we teaching our new doctors about perimenopause and menopause now?
I teach
I'm
the
gonna let
class.
Susan
I
take
give the
that. We
lecture,
do
so
teach them, yeah.
whatever I'm telling you, I'm telling them, I think would be the answer.
Yeah. Let's say at University of Washington, it's excellent.
Right. I think we have time for one more question. Let's see. There are a lot still in here. Oh, this is actually a good one. Should we just continue seeing our family medicine physician for menopause, or should we be seeing an OBGYN? When is it time to seek out specialty care?
So Linda, and I saw another question about who's a good provider. So the North American Menopause Society, Linda is a certified menopause practitioner. She's taken the exam for this. And so you can go to the NAMS website and look for providers that are certified, just like Dr. Mahaloff is. And these are good folks to go to. If you ask your family physician and they aren't giving you answers that seem right, then you really should seek out a gynecologist for this. If you choose not to take hormones, it's almost more important because your non-hormonal options are not well understood by our family medicine colleagues.
Very diplomatically put. And I would agree completely. We are happy, your gynecologist is happy to see you about these topics. Let me just put it that way. And other providers may be interested as well.
Well, thank you so much for this conversation. It was really informative. I certainly appreciated it as someone in the perimenopausal age range. So lots to learn. We will be sending out this webinar recording to everyone who registered, and it will also be on the Right is Wearing website if you want to share with friends.
I just wanted to say that Dr. Mahaloff and I are happy. There were so many questions. You can email us, feel free. So our emails are on the slides there.
Yeah, and again, mine is LSM25. I didn't catch that on the slide
Great.
presentation before. Okay.
Thanks, everybody.
Thank you so much for having us.
That's
Yeah, exactly.
Heart, right? Thanks, everybody.
Thanks so
Thank
much.
you.
Bye-bye.